Hello, here is my video on an intubation of a term neonate. This is one of our babies on the special care unit who unfortunately had to be admitted due to increased respiratory distress. Despite the fact CPAP settings, as you can see here, were 7 centimetres and 40%, the baby still had this significant work of breathing. Gases were poor, so the decision was made to intubate. And here we have at the top an introducer, intratracheal tube and a CO2 detector. Here is how you insert your introducer into an ET tube. Please take care not to insert the introducer beyond the distance of the ET tube and pull it back like so. Bend at the top, place it carefully in a twist around so that it stays in place but not so tight that it's difficult to unravel. The introducer then allows you to bend the tube into a position which will be more beneficial when it comes to inserting into the baby's oropharynx. Position the baby with head down and set up your ventilator for the settings that you require. Here we see the number of hands which it takes. First of all, we'll remove the CPAP from baby's head. And I will use a neopuff there in my left hand, and now in my right hand, to maintain baby's oxygenation. Now I'll show you the procedure done on a mannequin from a different view. My right finger, index finger, is protecting the gums as I insert the video gyroscope. And this is the image you can see on the video gyroscope, with the vocal cords coming into view just at the top of the screen. It's more beneficial to try and encourage the vocal cords to be more central in the view. It's quite high up, unfortunately, but I did manage to get the tube in place. Here is the distances. You can pause and document those down if you like. Remove the introducer as so. Swiftly attach the CO2 detector and then attach the ventilator tubing on there. If the tube is in the right place, then CO2 will be emitted by the baby's lungs and you will see the CO2 detector change yellow as seen there.
We get morphine.
Now you can see the baby is aware and alert, and I'm using the CPAP via neopuff to administer some pressure, but you can just see the baby's ribs working hard still there. My colleague is about to administer morphine. It's important you administer morphine first. The next drug we will give is succinylphonium in our hospital, which is a muscle relaxant. If you give the muscle relaxant before the morphine, it would be quite cruel, as this would be paralysing the baby whilst they still felt, and that could be painful. So it's important you give morphine first, allow it enough time to take action before administering the succinylphonium. Once the succinylphonium is administered, you see the baby then stops breathing by themselves, so I have to provide the ventilation using the neopuff. You can just see that at the top of the image there. Once the whole team's happy, we proceed to intubation. Now on the right you can see the side view, and on the left there's the view from the gyroscope itself. See the pool of secretions here, which is swiftly sorted out with a little bit of suctioning. And now you can see the esophagus, where the OG tube, that white tube, is going directly down into the stomach. Pulling back gradually with the laryngoscope, we just start to see the vocal cords coming into play there at the top. Not the best view, so we can see now my consultant's finger coming in and providing cricoid pressure, which presses on the outside of the neck, and then you can see the vocal cords at the top of the left image. And thankfully the tube passes relatively easy directly in. Now we have a tube which has been placed past the vocal cords and providing ventilation breaths. Immediately what we want to do is ensure that the CO2 detector is changing yellow, as you can see here. and my colleague is listening on both sides of the chest to ensure equal and good air entry on both sides. And my colleagues are preparing the neo bar, which is a helpful tool to keep the ET tube in place. Again, you can see how many hands it takes. Everybody's keenly paying attention to the baby, and the neo bar placed like a mustache over the top of the ET tube often should look like that. Once you're happy your tube is fixed, what you need to do is arrange for a chest x-ray. As you can see here on this chest x-ray, it shows signs of congenital pneumonia, and the ET tube looks like it's nicely 1.5 centimeters above the carina. We're happy with this position. If you were not happy, it'd be important to change the tube's position, make sure you document it accurately, and re-x-ray. Now we plan to administer surfactant down the ET tube. My colleague has prepared the administration tube, as you can just see there at the top of the image, and it just places directly down the ET tube, not beyond the point at which you can see, and if you squirt too fast, unfortunately that's what happens, it squirts back out the top. So he slowed down with his rate, and just underneath the nurse's fingers there, you can see bubbling of the surfactant up the tube, and then it falls back down as it goes down into the lung. The first dose of surfactant should be 200 milligrams per kilogram, and any further dose required would be 100 milligrams per kilogram. These doses are available on the neonate app. Once you have administered all the surfactant from the syringe, then you can re-administer the ventilation. Big thank you to everyone involved.